Today, we're opening the case file on one of medicine's most dangerous and, frankly, misunderstood conditions, acute respiratory distress syndrome, or ARDS. Now, for decades, it's been a bit of a hidden killer, but a brand new global definition is changing everything we thought we knew about how to find it.
So just try to imagine the sensation of drowning, but there's no water anywhere in sight. That's the terrifying reality for a patient with ARDS. It is, quite literally, an internal flood, an assault on the very organs we need for every single breath we take.
So what is it officially? Well, ARDS is what happens when a widespread, really severe inflammation causes the tiny air sacs in the lungs, the alveoli, to become leaky. Protein-rich fluid just pours in, and that leads to what we call pulmonary edema. But here's the crucial point. This isn't because the heart is failing. This is a direct attack on the lungs themselves. Okay, so let's properly open up this case file and start looking at the evidence. When we're trying to get a diagnosis, clinicians are trained to spot a very specific set of clues that point directly to ARDS. And these are the four big ones, the clinical hallmarks. First up, it happens fast. We're talking an acute onset within hours or maybe a few days. Second, the patient gets severe hypoxemia. That means dangerously low oxygen in the blood that just doesn't seem to get much better, even when you give them extra oxygen. Third, the lungs themselves become stiff and hard to inflate, which doctors call decreased compliance. And finally, you see it on the scans. Things like X-rays show bilateral infiltrates, and that's the visual proof that fluid is flooding both lungs. So the big question is, what kicks off this catastrophic chain of events? Well, our investigation reveals two main culprits, two really distinct paths that unfortunately both lead to the exact same devastating place.
Okay, so the injury can be direct, meaning the attack starts right there in the lungs. Think of something like a bad pneumonia or aspirating stomach contents. It's a direct, localized assault. Or it can be indirect, and this is when a problem somewhere else in the body, say sepsis or pancreatitis, unleashes this massive body-wide inflammatory storm, and the lungs just become the primary collateral damage.
And what I think is really fascinating about this breakdown is how it shows the specific targets. So with a direct injury, the damage is to the alveolar epithelium. That's the actual lining of the air sacs. But with an indirect injury, from things like sepsis or even a reaction to a massive blood transfusion, the attack starts on the vascular endothelium, the lining of the tiny blood vessels in the lungs. Two totally different starting points, but they both end in the same place, lung failure.
All right, now let's zoom all the way in. We're going microscopic to witness this attack as it actually unfolds. You see, ARDS isn't just one event. It progresses through three distinct, pretty destructive phases.
First, you have the exudative phase. You can just call it the flood. This is that initial inflammatory storm where the barriers break down and fluid just gushes into the air sacs. Next comes the proliferative phase. This is when the body's repair crew rushes in, trying to regenerate cells and patch up the damage. For a lot of patients, this is where recovery starts. But for some, it moves on to that third phase, the fibrotic phase. This is where the repair process kind of goes haywire, leading to a lot of scarring and permanently stiff lungs.
And this right here brings us to the real climax of our story, the huge breakthrough in how we even identify this killer in the first place. See, to catch ARDS, you need a really clear definition, and for years, the definition itself was a big part of the problem.
Man, the hunt for a better definition has been a long one. The first major agreement was way back in 1994. Then in 2012, the Berlin definition became the gold standard. It was definitely more precise, but it had these major blind spots, which we're about to see. And that leads us to now, 2024, where we have a new global definition that's designed to be way more inclusive. And, this is the critical part, to catch ARDS much, much earlier.
So why was that old definition such a problem? Well, the Berlin rules were just too rigid. To even get the diagnosis, you pretty much had to be on a ventilator. It required an invasive arterial blood gas test to measure oxygen, and that meant patients on less invasive support, like high-flow nasal oxygen, were just completely missed. They didn't fit the box. And if you were in a hospital with limited resources, making the diagnosis was nearly impossible.
And this slide right here, this just illustrates the real-world impact perfectly. Just look at these three patients. All of them are critically ill. All of them have respiratory failure. But under those old 2012 Berlin rules, only the top patient, the one on the full mechanical ventilator, would officially get an ARDS diagnosis. The other two, they'd be missed. The 2024 update changes all of that, and it allows all three to be correctly identified. It's a huge deal.
So, what are these game-changing updates? Let's break it down. First, oxygen support. The new definition now includes patients on high-flow nasal oxygen. Game changer.
Second, oxygen measurement. It allows for the use of a simple pulse oximeter on the finger instead of that invasive arterial blood gas. And third, imaging. It now formally includes bedside lung ultrasound as a diagnostic tool, and that is absolutely massive for resource-limited settings all over the globe.
Okay, so now that we can identify ARDS earlier and in more people, how do we actually fight it? The response is a very careful, very calculated strategy, and it's all focused on one primary goal. You see, the cornerstone of managing ARDS is supportive care. There's no single magic bullet drug you can give. Instead, the whole goal is to support the body's functions while the lungs heal, and the absolute center of that strategy is something called lung protective ventilation. We have to help the patient breathe without causing any more harm.
The first key number you need to know is 6 milliliters per kilogram. This is the target tidal volume, basically the size of each breath the ventilator delivers. And it's based on the patient's predicted body weight, not their actual weight. The whole idea is to use smaller, much gentler breaths to avoid overstretching and doing more damage to that already fragile lung tissue.
The second key number is keeping the plateau pressure under 30 centimeters of water. Now, this measures the pressure inside the little air sacs when the breath is held just for a moment. Keeping it below this limit is absolutely critical to stop those alveoli from being put under too much stress, which could literally cause them to rupture.
But it's not just about the ventilator, right? Other strategies are totally vital. There's prone positioning, placing patients on their stomachs, which helps open up parts of the lung that were squished. Early corticosteroids can help tamp down that inflammation. Limiting IV fluids helps prevent even more liquid from ending up in the lungs. And of course, you have to aggressively treat the underlying cause, the sepsis or the pneumonia that started this whole mess.
So, in the end, this new global definition, it's so much more than just an academic exercise. It is a tool. It's a tool that allows doctors to identify a hidden killer earlier, in more patients and in more places all around the world. So the real question now is, will this broader, faster recognition finally be the key that turns the tide against one of critical care's most formidable enemies?